Thank you, Deputy Jones. In the case of People versus Murray, Dr. Murray is present with counsel, Mr. Chernoff, Mr. Flanagan, Mr. Gorgian, and Mr. Pena. The people by counsel, Mr. Walgren and Ms. Brazil. All 12 jurors and the alternates are present. To everybody, good morning, and to the jurors, once again, good morning and welcome. We're going to resume with the defense presentation. Mr. Chernoff, good morning. Please call your next witness.
It's Dr. Robert Waldman, Judge.
Thank you.
Sir, please raise your right hand. Do you solemnly state that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Please be seated. Please state your name for the record. Spell your first and last names.
Dr. Robert Waldman, R-O-B-E-R-T, W-A-L-D-M-A-N.
Dr. Waldman, good morning. Let
Morning.
me provide you with introductory instructions for every witness in every case. The first of which is to please sit back and relax. The second of which is to speak in a loud voice. That way everybody can hear you. And you don't really have to bend over into the mic because it's sensitive enough. The third, if you're called upon to provide a yes or no answer to a question, answer that way rather than using slang like uh-huh or uh-uh, which can be a little tricky. And lastly, please wait until you hear an entire question before you even start to respond, even though you may think you know what the question asks. Is that all okay?
Yes.
Thank you. This will be direct examination, Mr. Chernoff.
Thank you, Judge.
Thank you.
Doctor, good morning.
Morning.
Please tell us what you do for a living.
I'm a physician.
All right. And do you have a particular specialty?
I do. More than one. I specialize in internal medicine, nephrology, and addiction medicine.
Addiction medicine. What is that?
It's the evaluation and treatment of people with addictive disease.
All right. Give us some insight into how you got involved in addiction medicine, please.
At one of the hospitals that I worked at, there was an addiction facility actively treating patients, and they asked me to get involved in seeing and evaluating and treating their patients in 1988.
All right. And so for the last 30 years, or 20 years?
23.
23 years, all right. You've been treating those with addictions.
Yes.
What is your background, medical background? You said it was internal medicine. When did you receive your medical degree? Where?
1974 to 1978, Hahnemann Medical College, Philadelphia, Pennsylvania. 1978 to 1981, medical internship and residency at Hahnemann University Hospital, Philadelphia, Pennsylvania. 1981 to 1983, fellowship in nephrology, Temple University Hospital, Philadelphia, Pennsylvania.
All right, let's talk about addiction medicine. What does addiction medicine encompass? What are some of the things that are, obviously identifying addiction is one of them, right?
Yes.
But there's much more to it than that.
Yes.
What does it encompass?
Again, it's broad. People come to me looking for help to stop drinking, to stop using drugs, and I assist them in comfortably stopping and in finding a therapeutic environment to treat the addiction and the underlying illnesses so that they can move forward in sobriety.
So if an individual comes to you with what is perceived to be a problem, you would address first, you would determine whether or not there is a problem. Is that right?
Yeah, usually when they come to me, it's pretty obvious. They're coming to me for help. Very rarely are they coming to me for me to assist them in making a diagnosis of whether or not they have addiction.
And this is they come to your office for that?
Primarily.
All right. Now, let's say an individual comes to your office because he believes he has a problem. What is the first thing that you will do to address that issue?
Complete history,
All right, and how do you do that?
Interview.
Okay. And could you give us some ideas about the questions that you would ask that person? What are you looking for in addiction medicine to determine whether or not, A, this person has an addiction, and B, whether you can help them?
But you're looking for drugs of abuse, you're looking for repetitive use, you're looking for long-term use, you're looking for comorbidities, you're looking for a history of age of onset, you take a history of all substances of abuse to find out what else they use besides what they're openly telling you. You take a history of adverse consequences of use, such as legal issues, social issues, etc. You look for underlying causes.
So you're going to take a survey of this individual. You're going to have interviews of this individual. Is that correct?
Well,
Both
what you would do is you would take really a complete medical history, but focus, aside from the routine, also on those aspects of addiction that are going to be important, because they'll present with a complaint: alcohol abuse addiction, opioid abuse addiction.
Now, on occasion, when people come to see you, do they come to see you denying any problem?
Occasionally, they're brought by family or friends or other referring agents in denial that they have a problem.
Now, what if this individual comes to you and he says, look, I don't have a problem, I don't drink excessively or use excessively, I don't have any problems at work or home? What would you do in response to that?
Again, you take a complete history, you develop an understanding of what they've been doing, what their behavior is, and consequences of that behavior, and then you try to enlighten them about the adverse consequences of their behavior. So, for instance, 2 or 3 DUIs would be an adverse consequence, even though it might not have been their fault.
What, if you were to take on a patient, now, do you take on any patient that walks through your door?
For the most part.
If they want help, you're going to help them?
Yes.
When you take on a patient and you've identified now that there is a problem, what do you do next? What's the next step?
I propose a treatment program.
Okay, now, the treatment programs, are they going to be the same for any type of addiction?
No, varied.
All right, let's talk about the types of addictions that you handle. What types of substances in the last 20 years or so have you handled that people were addicted to?
Well, let's start with alcohol.
Okay, that's a big one.
Common.
All right. And what are some of the things you look for when a person comes to you and says that they may have trouble with alcohol? What kind of adverse consequences?
Primarily legal, but also medical. So the obvious things we all know about: liver disease. So I'm gonna make sure I get laboratory studies on them to provide them further objective data to support my understanding. I'm going to interview them with respect, again, primarily to legal consequences and social consequences. Has it cost you your job? Has it cost you relationships? Has it caused you legal issues?
All right. Now, you also deal with addictions that involve illegal drugs. Is that right?
Yes.
Such as cocaine?
Yes.
Heroin, for instance, something
Yes.
like that? What about prescription medications?
Very common.
You say very common. How common?
I think the last data I saw were maybe 2.2 million persons in the United States, 2005-06, the last survey I saw, addicted to oxycodone and other prescription opiates.
What does when a person comes to you with prescription medication problems, does that provide you different concerns than you would have with alcohol or heroin or cocaine?
No.
Tell us what prescription medications would be, how a person who comes to you would get addicted to prescription medications. How would that typically occur?
Well, one way is prescription use. I mean, there's There is lots of iatrogenic addiction, but all of the drugs.
Could you explain what that is?
Iatrogenic.
Yes.
IATROGENIC, iatrogenic, and that means prescription that a doctor provided.
Okay. Now, is there a difference between dependence and addiction?
Yes, I think so.
Okay. What would, in your opinion, what would be the difference?
Well, addiction, my definition of addiction that I like to use is a repetitive behavior pattern that can result in harm or illness to the individual, even loss of life, that continues despite adverse consequences. And dependence implies a physical need for a substance, but it's not a behavior pattern. And it might not be associated with adverse consequences. Dependence, for instance, might be an elective surgery that required a lot of pain medication postoperatively and resulted in a few weeks of opioid use, and then you might feel ill when you stop the opioid precipitously.
Have you, in your practice in the last 20-some-odd years, have you treated professional athletes?
Yes.
Celebrities?
Yes.
And have you treated these individuals for prescription medication abuse?
Yes.
Now, when an athlete, let's take a professional athlete, for instance, let's say that he is injured, and he were to go to a doctor and get pain pills. At what point, in your view, would it become clear that that individual has developed a dependence on those pain pills? What are the symptoms? What are the signs that this has become a problem, that this has become a dependence?
It can be very subtle, but you would look for behavioral changes, you'd look for performance changes, you would look for use beyond the prescribed use, such as for sleep, for energy, for anxiety, particularly with a pain medication.
What about symptoms of withdrawal? Is that something you would look for to look to see if dependence has set in?
Well, if you have a withdrawal syndrome, that implies that there was dependence, physical dependence.
All right, let's talk about some specific drugs. You mentioned OxyContin. Is that, for lack of a better word, popping up quite a bit in your practice lately?
OxyContin abuse is fairly an epidemic.
Now, OxyContin is what type of drug?
It's an opioid.
It's an opioid. And there are other opioids in the same class of drugs as OxyContin. Is that right?
Yes.
Now, by example, let's look at benzodiazepines. All right?
Okay.
What's a benzodiazepine?
The classic and most commonly recognized benzodiazepine is probably Valium. It's a sedative.
And Valium came into being back in, was it the 70s?
I don't know.
Okay.
It's an old drug.
It's an old drug. But after Valium, other drugs, benzodiazepines sort of branched off from Valium, and other benzos came on the market. Is that fair to say?
Yes.
Now, let's look at opioids. Am I pronouncing that right?
Yes.
Opioids. And we talked about OxyContin. Now, there are other, you said, opioids on the market as well. Could you mention those? Could you name those?
Codeine, Demerol, Dilaudid, fentanyl, Tramadol. There's a lot.
Let's talk about Demerol. How old a drug is that? How long has that been on the market?
From before I was in practice.
All right. It's an old drug.
Old.
And since Demerol, there have been other opioids that have come on the market till now, where we have actually, what would be the newest opioid?
I don't know.
OxyContin's pretty new, though.
OxyContin is not the newest, but it's newer.
All right. What's the purpose of an opioid?
Pain relief.
A doctor's purpose for prescribing
Pain relief.
pain relief. And that is the number one reason, or is that the only reason a doctor should prescribe an opioid?
I believe so.
All right. Demerol, if it has been around for as long since you've been a doctor, do you see a lot of Demerol addiction in
No.
your practice? Do you know? Can you tell us why that is?
I think OxyContin is more readily available. It's probably more potent as well.
When's the last time you saw a Demerol addiction?
I don't recall. A long time.
And that was when they were giving it in pills. Is that right?
I think it's always been available, both injectable and by pill.
Okay. Was that what you saw was pill addiction? Or do you remember? Do you remember?
Tell me your question, please.
You said it's been a long time ago.
I don't ever recall
All right.
recently seeing Demerol addiction.
When you are treating an opioid addiction, whether it be OxyContin, Demerol, Dilaudid, do you see the same types of symptoms in those drugs in your patients?
Symptoms
In other words, the same effects it would have on your patients when they're on the drugs, the same withdrawal symptoms that they have when they're off the drugs. Do you see this?
Similar.
Similar. And what would be, let's say an individual came to you with a problem with painkillers, OxyContin, let's say, or Demerol. What would be the course of treatment that you would suggest once you determined that they were dependent or addicted?
Stop the medication and seek treatment to ease the discomfort associated with stopping the medication. And that's the primary reason that those people present to my office.
Let's talk about, do you find it difficult to convince addicts to stop medications?
Well, people come to me because 99.9% of the time they recognize they have the problem and they're presenting voluntarily to get proper treatment.
And despite all that, despite their best intentions and desires, do you still find it difficult to convince them to stop using the drug?
No. The ones who present voluntarily want to stop the drug.
Okay. And what treatment program do you provide for them to help them get off? You say stop the drug. Do you just stop it, say just stop it, and then go home?
Well, the first thing I always suggest is that an individual go to a treatment facility where they can get well monitored and well treated and properly assessed for their addictive disease and, again, the comorbidities, so that they can get treatment from an addictionologist, from a psychiatrist, from a therapist, and get proper vital signs monitoring and get state-of-the-art treatment.
All right, and so you would recommend them to a particular facility?
Any facility.
All right. After you recommend them to that facility, do you continue to treat them in that facility?
If I consult at that facility, I'll treat them there. If they go to another facility, then they'll be treated by the physicians that work at that given facility.
And let's talk about stopping painkillers. If a particular individual you've made a determination they're addicted to painkillers, do you consider it safe for them just to go cold turkey, so to speak?
It's not safe, but it's also extremely uncomfortable. And most persons who have addiction and are not in denial about it have tried themselves to discontinue and have met failure. And that's why they present. They're very fearful of the discomfort associated with cessation of their opioid use, and so they're coming for appropriate medical help.
All right, let's talk about those individuals that do have a problem with denial. Explain what that is, a denial problem in your practice.
Well, people who are in denial about their addiction basically are just dishonest. They tell all the people around them, family, friends, etc., spouses, children, parents, that they don't have a problem.
And why would they, if it's so obvious that they have this problem, why would they deny it?
And probably each individual has a different reason, but it's just that denial is very common. People don't want to give up their daily routine, their livelihood, their environment, and most of the time, if they're in denial and they're confronted by family and friends, part of the confrontation probably involves an intervention. If there's an intervention, many of you have probably seen on television that intervention show. I mean, it's very realistic. They're asked to leave their life for a period of time, go to a treatment facility where they have to follow somebody else's rules, and they have obligations and responsibilities, and there's discomfort associated with it, and they're unwilling.
Let's talk about the patterns of those individuals, those addicts who are in denial. Is it always the case that the family knows exactly what the family member, the addicted family member, is doing?
No, they hide it.
How do they hide it? What are ways that they would do that?
Well, they hide the use. They don't talk about the use. They keep the pills private or whatever they're using, and they do everything in their power to maintain their privacy and discretion.
In addition to hiding it from family members, do you see examples where they also hide it from doctors?
I have cared for a number of patients who will obtain prescription medications from a variety of pharmacies, a variety of doctors.
Is that referred to as doctor shopping?
Pardon me?
Doctor shopping? Is that how it's the slang for that particular activity?
Yes, one of them.
How would they keep it from family and friends, typically?
They just don't use in front of them.
Different schedules, for instance?
In a bathroom, in a bedroom, at work. Addicts who are in denial are very good at compartmentalizing. What that means is they keep different aspects of their life separate from the other aspects of their life. So what happens at work and what happens at home aren't intermingled.
I want to go back to let's say that you have a patient in front of you that wants help, okay? And you have you said the first thing that you do is to get them, first of all, stop using the drug, right?
Correct.
And we talked about cold turkey and how uncomfortable that was. What process do you go through to help them stop this drug?
Well, excuse me, understanding the symptoms of withdrawal, you direct medication therapy at each of those symptoms.
All right. Well, let's take, for example, opioid withdrawal. Let's say that a person comes to you, has a Demerol addiction, OxyContin addiction, Dilaudid addiction. What would you do to try to get them off that drug, or at least to help them get off the drug?
Well, there's probably two ways that are most commonly recommended currently. One would be opioid substitution therapy, and the two medications that one uses to do that are buprenorphine or methadone. I don't prescribe methadone, so patients do come to me for buprenorphine.
Could you spell that for us?
You're really testing my English background.
Well, some of us need to write it down.
buprenorphine.
Thank you.
Did I get that? Okay. Buprenorphine is a partial opioid receptor agonist, so that means it stimulates the opioid receptor but does not result in full expression of that receptor. And it's a really good medicine for immediately ameliorating the symptoms of withdrawal, but one must enter withdrawal first. So some patients come to me because they've read about buprenorphine and they're interested in getting a prescription for that to help them withdraw from their opioid.
What's the purpose of using an opioid, something that would stimulate an opioid receptor? What would be the purpose of that?
Well, the technique is, again, it's the broad heading would be opioid substitution therapy. And so what you're doing is you're substituting a legal prescribed opioid for an opioid that's being obtained illicitly. And you prescribe it in doses to initially make the patient comfortable, and then in a tapering schedule so that they come off comfortably. But the beauty of that is that that can be office-based, and it doesn't require hospital care or even facility care. It's very safe.
The purpose of that is to try to make the patient comfortable.
Yes, because the addict's biggest fear is that you're not going to respect the amount of discomfort that they're about to experience, and so they really need to trust that you're going to look after their problem. The second method of withdrawing is a more old-fashioned technique, and you just give lots of sedation, benzodiazepines, muscle relaxants, and other similar sedatives to treat all the symptoms of withdrawal without doing opioid substitution. And they're subject to patient and doctor choice, and they're both acceptable and safe techniques.
Tell us what types of withdrawal symptoms you would expect to find for someone that's withdrawing from Demerol.
Again, probably the symptoms from opioid withdrawal are not reliant on the specific opioid, but they consist of sweating, diaphoresis.
What's diaphoresis?
Sweating.
Okay.
Tachycardia.
Which is?
Increased heart rate.
Okay.
Muscular aches and pains, bone pain, nausea, abdominal cramps, diarrhea, severe anxiety, severe restlessness, insomnia.
How about chills?
Yeah, thank you. Temperature dysregulation, chills, hot and cold chills, are very common.
If somebody were complaining about feeling hot on one side of their body and cold on the other, would that be consistent with withdrawal from an opioid?
It could be. And most people who have experienced it will describe it as the worst case of influenza that they ever had. It's very, very uncomfortable.
And so you try to ameliorate these pains, this discomfort, with a drug to allow them to get through those symptoms.
That would be multiple drugs.
Multiple drugs.
Yes.
Okay. Well, let's go to those. We've already talked about, I can't pronounce it,
buprenorphine.
All right, buprenorphine.
Probably it's better to use the trade name Subutex or Suboxone. Those are easier, huh?
Yeah. Well, I'm glad they nicknamed it. So.
We probably need a spelling.
Thank you for the easy one. Subutex, S-U-B-U-T-E-X, Suboxone, S-U-B-O-X-O-N-E.
Thank you.
And what other drugs do you provide?
Well, the commonly used ones are clonidine, which is a centrally active alpha receptor stimulant. It's commonly used as a blood pressure medication. It's a very, very, very mild opiate receptor agonist or stimulator. It takes the edge off the withdrawal a bit. It also treats the overactivity or hyperactivity of the autonomic nervous system, which is a common, which is the cause of all the commonly recognized symptoms that I mentioned. You use vigorous sedation with benzodiazepines. Valium is commonly used. Ativan or lorazepam is commonly used. Sometimes you use phenobarbital. That's a good sedative. You use muscle relaxants such as Robaxin, Soma, Scalaxin, whatever one's individual choice is. You use antidiarrheals. You use sedatives for sleep, and you use anti-seizure meds. It's basically a full court press. You're very vigorous in medicating. The patient's greatest fear is that they're going to be uncomfortable. So the more you can do to take away the discomfort, the better you're going to do with the patient.
You mentioned lorazepam and that panoply of drugs that are used, Ativan. In your experience, do you find that those individuals who are going through withdrawal from painkillers, opioids, turn to benzodiazepines, supplement with the benzodiazepines?
Persons with well-established and active addictive disease are amateur pharmacists, and they self-treat. Ultimately, that's really what they're doing as an addict. And if they're uncomfortable, they'll take whatever they can get to make themselves comfortable. Many, not all, but many have experience with polysubstances of abuse.
What does benzodiazepines do for an individual?
They're tremendous at relieving anxiety.
All right. And one of the symptoms that you said exists in withdrawal from opioids is anxiety.
Severe anxiety.
Tremendous anxiety.
Tremendous.
Now, in addition to the drugs that are provided for detox, what else is done for the patient to try to make them comfortable, try to get them through this withdrawal period?
I think that's really it. Emotional support, psychological support.
Where is this detox usually held?
It can be anywhere, wherever the patient wants.
At home?
Buprenorphine, for instance, was created for office-based, i.e., home detox, home treatment of opioid dependency.
How long is it required to be on these drugs to get through these withdrawal symptoms? How long for opioids would it be necessary to stay on those drugs?
It's variable. So you need to reassess, reevaluate, and the medications that are used to treat withdrawal are, for the most part, not terribly pleasant to take because they're very sedating. And so when you have experience caring for someone in withdrawal, you develop experience knowing when they're no longer needing the meds. They've come to you to be comfortably withdrawn from the opioid, and so very often they'll tell you they don't need meds anymore.
All right.
But you can see the change in demeanor, in countenance. It's fairly obvious that you have someone who's become much more comfortable. And then, of course, if they're excessively sedated, you're going to titrate your medication doses down. By the same token, if they're uncomfortable, you might titrate your medication doses up. So you go with a ballpark figure, see how it works, and move on from there.
Is the period of now after the patient has gone to past the period of withdrawal, then what does the treatment consist of?
Primarily group and individual therapy, AA.
Are you familiar with a process known as rapid detox?
I've never done it, but I'm familiar with it.
What is that process?
It's the process of rapidly withdrawing somebody from opioid dependency using high doses of intravenous opioid antagonists. But it needs to be done under hospital care, general anesthesia, and ventilatory support so that the patient can be treated vigorously.
Why don't you do rapid detox? Why do you not involve yourself in that?
Well, I believe in treatment, not just detox, so I take people under my care who want treatment for opioid dependency, which is multifactorial. It involves, again, individual and group therapy, AA, all of the social aspects of the addictive disease have to be addressed if you want to have a successful treatment program and plan. And rapid detox is just what it says, rapid detox. It's really not a treatment. It's just a risky way to stop using opioids.
And then the problem still persists.
Then you have, for lack of a better term, then you have a dry drunk.
All right. Tell me about the dangers associated with detox, rapid detox, or any detox. What are the physical dangers associated with that?
Well, since I'm more familiar with detox that is not quote-unquote rapid detox, I'll start there. Again, the main dangers really come from the overactivity of the autonomic nervous system. Opioids lower the level of activity. When you remove the opioid, as I tell my patients to do by stopping it, the autonomic nervous system goes into hyperdrive, and that's what produces all of the symptoms of the withdrawal syndrome. And so